All right, everybody, ready to go deep on some pharmacology.
Always.
Today, we're diving deep into the world of intravenous anesthetics and analgesics, the bread and butter of managing pain and consciousness for, well, just about everything we do.
Can't argue with that.
We're going to be using excerpts from Dr. Farhad's The Anesthesia Academy as our guide.
A classic.
By the end of this deep dive, you'll be able to choose the right anesthetic or analgesic for any situation, no problem.
And maybe even learn a fun fact or two. You never know.
So let's start with the basics. What exactly are intravenous anesthetics and why are they so important?
Well, think of them as the off switch for the brain, temporarily, of course. They allow us to perform procedures safely and painlessly, whether it's a minor procedure or a major surgery.
Sounds pretty powerful. How do they actually work?
They target a specific part of the brain called the reticular activating system, the brain's on switch for wakefulness.
So they essentially flip that switch to off.
Yep. And they do it by enhancing the effects of GABA, the brain's natural calming agent.
So it's like hitting the mute button on the brain's activity.
Pretty much.
That's pretty amazing when you think about it.
It is.
So let's talk about some of the specific drugs in this category. Where should we start?
Well, let's start with the old school, the barbiturates, like thiopental.
Thiobendil, the one with the garlic breath side effect.
Oh, that's the one. It's harmless, but definitely memorable.
I can imagine. So what are the key things to keep in mind with barbiturates?
The main thing is their context-sensitive half-life.
Meaning?
The longer you infuse them, the longer they stay in the body, leading to longer recovery times.
Got it. So short infusions for short procedures.
Exactly. Now, moving on to a group we use all the time, the benzodiazepines.
Like diazepam and midazolam, the chill pills.
You got it. Both great for sedation and pre-op anxiety.
But they work a little differently, right?
Yeah, diazepam hangs around a lot longer than midazolam.
So choose your benzo based on how long you need the chill to last.
Exactly. But always keep a close eye on respiratory function, especially when using multiple medications.
Right, safety first. Now for something a little more interesting, ketamine.
Ah, ketamine,
Well,
dissociative anesthetic.
known for its unique ability to make you feel like you're on a different planet.
It can cause some pretty wild hallucinations, but it also has some really valuable uses, like in asthmatic patients.
Because it's a bronchodilator.
Right, again. But remember to pre-medicate with an anticholinergic to avoid that excessive drooling.
Wouldn't want our patients to drown in their own saliva. Okay, what about etomidate?
Etomidate is great for keeping blood pressure stable, making it ideal for patients with cardiovascular issues.
This is like the Zen master of anesthetics.
I like that. But it does have a downside, the risk of adrenocortical suppression with repeated doses.
So we typically use it for induction rather than maintenance.
Exactly.
Okay, let's talk about the superstar of intravenous anesthetics, propofol.
The smooth operator, known for its rapid onset and recovery.
It's like the anesthetic milkshake, but we have to be extra careful with sterility, right?
Absolutely. And we can't forget about propofol infusion syndrome, a rare but serious complication.
So monitoring is key with propofol. Now what about its cousin, fospropofol?
Fospropofol is like propofol but water-soluble, making it less painful to inject.
So less pain for the patient.
Exactly. It's a good option for conscious sedation, but it's a bit slower than propofol.
Got it. Well, that was quite the rundown of intravenous anesthetics.
We covered a lot of ground.
But I think the main takeaway is that each drug has its own unique profile, and understanding those nuances is key to providing safe and effective care.
Couldn't have said it better myself.
Yeah.
But it's not just about the drug itself. It's about understanding how it interacts with each individual patient.
You're right. Every patient is different and will respond to these medications differently.
Absolutely. And speaking of individual responses, let's move on to the next big category, opioids.
The heavy hitters in pain management.
With a lot of baggage.
We'll unpack all of that in part 2 of this deep dive. Stay tuned.
Okay, let's dive into the world of opioids.
The heavy hitters.
Absolutely. Incredibly effective for pain relief.
But they also come with a lot of baggage, right?
Unfortunately, yes. A lot of potential for side effects and, misuse.
Yeah, definitely need to use them carefully.
Absolutely. So let's start with how they actually work.
Okay, how do opioids actually relieve pain?
They work by mimicking the body's natural pain relief system.
So like they're impersonating our own endorphins.
Yeah, sort of. They bind to opioid receptors, mostly those MUN receptors, in the brain and spinal cord.
Okay, and what does that do?
Blocks those pain signals from reaching the brain.
Ah, so the brain never gets the ouch message.
Exactly. Plus, they trigger the release of endorphins, those natural feel-good chemicals.
So it's like a double whammy, blocking pain and boosting good feeling.
Exactly.
But it's not all sunshine and rainbows, right?
No, opioids can also cause sedation, euphoria, and of course, respiratory depression.
That's the big one we always worry about.
Absolutely, and there are different types of opioid receptors that contribute to these different effects.
Making it even more complex.
It is, but let's talk about some specific opioids, like morphine, the classic.
Morphine, the OG, still going strong.
Yes, it's been used for centuries for moderate to severe pain, still very effective.
I've always thought of morphine as the slow and steady opioid.
Yeah, good analogy. It has a relatively long duration of action.
Provides nice, sustained pain relief.
Exactly, but it can also be quite sedating.
Definitely something to keep in mind.
Now let's shift gears to a much faster-acting opioid, fentanyl.
Fentanyl, much more intense.
About 100 times more potent than morphine, in fact.
Wow, that's a big difference.
It is very rapid onset, short duration of action.
Making it ideal for certain situations, like during surgery.
Yeah, quick pain relief when you need it.
But with great power comes great responsibility, right?
Absolutely. Much higher risk of respiratory depression with fentanyl.
Definitely need to be extra careful with dosing.
Absolutely. And then we have sufentanil, even more potent than fentanyl.
Like the fentanyl of fentanyl.
Yeah, 5 to 10 times more potent, even faster onset.
So for very specific situations where you need that super fast, super strong analgesia.
Exactly, and it's often used in tiny doses for short procedures.
Okay, so we have this whole spectrum of opioids. How do we choose the right one?
That's where this concept of context-sensitive half-time comes in.
Okay, I've heard that term before, but remind me, what is it exactly?
It's basically how long the drug takes to clear the system after an infusion.
So it's not just about the drug itself, it's about how long it's given for.
Exactly, and the longer the infusion, the longer the drug hangs around.
So we need to factor that in when planning for post-operative pain management.
Absolutely. We don't want our patients to be overly sedated for days after surgery.
Definitely not. Now, what about meperidine? I remember that one from residency.
Meperidine, well, it's good for shivering.
Yeah, more effective than morphine or fentanyl for that.
But it has a nasty metabolite. Norperidine can be toxic to the brain.
Especially in patients with kidney problems.
Right, so definitely avoid meperidine in those patients.
Got it. Now, what about remifentanil, another synthetic opioid I've heard a lot about?
Remifentanil is ultra short acting, like the sprinter of the opioid world.
Oh, I like that analogy. In and out, quick action.
Exactly. Great for situations where you need really tight control over pain relief.
But there's a catch, isn't there?
Yep, remifentanil can lead to something called opioid-induced hyperalgesia.
Wait, so the painkiller can actually make the pain worse?
I know, it sounds crazy, but it can happen. The nervous system can actually become more sensitive to pain.
So it's like the body is fighting back against the opioid.
In a way, yes.
So how do we prevent that?
But that's where multimodal analgesia comes in.
Combining different types of pain relievers.
Exactly. So we're not relying on just one drug, and we can reduce the opioid dose.
Which minimizes the risk of side effects, like respiratory depression.
And tolerance and dependence.
Right. It's all about finding that balance between pain relief and minimizing those risks.
Absolutely. And multimodal analgesia can also target different types of pain.
Like using an NSAID for inflammation, an opioid for spinal cord pain signals, and a local anesthetic at the surgical site.
Yeah, it's like having a whole toolbox of pain-fighting tools.
And we choose the right tools for each individual patient.
Exactly.
Now, we can't talk about opioids without addressing the elephant in the room, their potential for abuse and addiction.
It's a serious issue and one we need to be very mindful of.
Especially with the more potent opioids.
Absolutely. Careful patient assessment, monitoring for signs of dependence, patient education.
It's all crucial.
It is. It's about balancing the need for pain relief with the risks involved.
It's a delicate balance.
Absolutely.
Well, this has been quite a journey through the world of opioids, from the classic morphine to the super potent sufentanil.
We've seen both the power and the peril of these medications.
Absolutely. And it's clear that understanding their mechanisms, their kinetics, and their potential for side effects is absolutely crucial for using them safely and effectively.
Couldn't agree more.
Okay, so we've covered the drugs that knock you out and the drugs that take the edge off pain.
What's left?
What about the patients who can't tolerate opioids or need a different approach?
Ah, that's where those non-opioid analgesics come in.
The unsung heroes of pain management.
And we'll dive into those exciting alternatives in part 3 of this deep dive.
Okay, so we've talked about the drugs that can put you out like a light and the ones that can take the edge off pain, But what about those patients who need something a little different?
That's where those non-opioid analgesics come in.
Yeah, they might not be as flashy as opioids or anesthetics, but they're essential for multimodal pain management.
Absolutely. They work in different ways, targeting different pathways, and often come with fewer side effects.
Let's start with a group we're all familiar with, the NSAIDs, those trusty nonsteroidal anti-inflammatory drugs.
The ones we find in every medicine cabinet.
Ibuprofen, naproxen, those are the big names.
Yeah, they work by blocking the production of prostaglandins.
Prostaglandins, those are the pain and inflammation messengers, right?
Exactly. So NCs are like hitting the mute button on those signals.
So less pain, less inflammation, win-win.
But there are different types of NSAIDs, and it's important to know the difference.
Okay, like what?
Well, there are two main enzymes they target, COX-1 and COX-2.
And some NSAIDs block both, right?
Yeah, those are the non-selective NSAIDs, like ibuprofen and naproxen, and that's why they can cause GI side effects.
Because COX-1 is involved in protecting the stomach lining.
Exactly.
So that's where the COX-2 inhibitors come in, like celecoxib.
Right. They were designed to target COX-2 specifically, sparing the stomach.
A more targeted approach.
But they came with their own set of risks, unfortunately.
Like an increased risk of heart attacks and strokes.
Yeah, it's a trade-off, and it highlights the importance of considering the individual patient when choosing medications.
Definitely no one-size-fits-all solution.
Absolutely.
Now, what about the OG of pain relievers? Aspirin.
Aspirin. Still going strong after all these years.
What makes it so special?
Aspirin irreversibly inhibits COX-1.
Irreversibly, what does that mean?
It means it binds to the enzyme and doesn't let go.
So its effects last longer than other NSAIDs.
Yeah, for the lifespan of that platelet, actually.
So we need to be careful with aspirin use before surgery.
Definitely, because of its effects on blood clotting.
Okay, now let's move on to another familiar face, acetaminophen.
Also known as paracetamol.
It's often grouped with NSAIDs, but it's not a true NSAID, right?
You're right. It relieves pain and fever, but doesn't have those anti-inflammatory effects.
So good for headaches and fevers, but not so much for swollen joints.
Exactly, and it seems to work primarily in the central nervous system.
So it's blocking pain signals in the brain itself.
That's the idea, but it's generally well tolerated.
But high doses can be bad for the liver.
Right, especially when combined with alcohol.
Good reminder. Now let's shift gears to a class of meds that were originally developed for epilepsy, but have become valuable for pain management. Gabapentin and pregabalin.
The multitaskers of the medication world.
They're especially good for neuropathic pain, right?
Yeah, like diabetic neuropathy or postherpetic neuralgia.
Those conditions where the nerves themselves are damaged.
Exactly.
So how do they work?
They bind to voltage-gated calcium channels.
Okay, and what does that do for pain?
It reduces the release of those excitatory neurotransmitters involved in pain signaling.
So they're calming down those overactive nerves.
Exactly. And because they work differently than opioids or NSAIDs, they can be a good option for patients who haven't had success with other treatments.
But dosing can be a bit tricky, right?
Yeah, gabapentin needs to be titrated slowly. Pregabalin can be titrated more quickly.
What about side effects?
Dizziness, sedation, weight gain are some of the common ones.
And we need to adjust the dose for patients with kidney problems.
Definitely, because they're excreted by the kidneys.
And there's some potential for abuse too, right?
Unfortunately, yes. Even though they're not opioids, they can still be misused.
So always be cautious, monitor patients closely, and weigh those risks and benefits.
Absolutely. Good practice with any medication.
Now, let's bring it all together. We've talked about all these different options, but how do they all fit into a multimodal approach?
Multimodal analgesia is all about using different medications that work in different ways to achieve better pain control.
It's like having a team of specialists, each with their own expertise, working together.
Exactly. So we can use lower doses of each drug, reducing the risk of side effects.
And we can target different types of pain more effectively.
Absolutely. An NSAID for inflammation, an opioid for severe pain, a local anesthetic at the surgical site.
It's about tailoring the approach to the individual patient.
Exactly. Using the right tools for the job.
Well, I think we've covered a ton of information in this deep dive into the world of anesthetics and analgesics.
It's been a whirlwind tour of pharmacology.
But I think the key message is that understanding these medications is crucial for providing safe and effective pain management.
Absolutely. It's about making informed decisions, considering the individual patient, and using a multimodal approach whenever possible.
Couldn't have said it better myself. So to all our listeners out there, keep learning, keep asking questions, and keep striving to be the best clinicians you can be.
And remember, knowledge is power, especially when it comes to patient care.
Until next time, stay curious and stay informed.